Hello, my name is Victor Perez, and this is my OBGYN rotation. I'll be talking about cervical dysplasia. So, I saw the patient on October 3rd, 2025 at 2 p.m. ID, 36-year-old Hispanic female, source self, which was reliable. Chief complaint, abnormal results from colposcopy, sent for preoperative clinic clearance. So HPI, Mrs. ACG is a 36-year-old G2P2002 female with history of cervical epithelial neoplasia, CIN 2 to 3, on colposcopy, presenting to preoperative Brooklyn Clinic for a cold knife conization. The patient initially presented for her annual gynecologic exam, during which a pap smear was done on September 25th, which showed HPV 18 detected in cytology suspicious for HSIL/CIN3. Scant benign endocervical epithelial with rare atypical squamous cell showing high NZ ratios. A colposcopy then was performed afterwards to confirm CIN2-3. The abnormal PAP and HPV findings were first noted on, again, September 25th, 2025, during her routine exam. She denies any factors that worsen or relieve her symptoms. She has not experienced any vaginal bleeding or pelvic discomfort. Since the procedure, the patient describes passing a small amount of brown discharge following the colposcopy, which was interpreted as old blood. She denies any foul odor, cramping, or pain. Discharge was vaginal only, with no pelvic or lower abdominal pain or radiation. Symptoms were mild and self-limited, no ongoing discomfort or systemic symptoms. The brown discharge occurred shortly after colposcopy and resolved spontaneously, no recurrent symptoms since that time. So medical history, she does have history of HPV infection. Colposcopy was done September of 2025. She had an appendectomy in 2024, C-section in 2023. She's on no medication and no known allergies. Social history, currently living at home with her husband and 2 children. She's never smoked in her life and no passive exposure, denies any alcohol use. Review of systems. So general denies fever, chills, night sweats, fatigue, or unintentional weight loss. Skin denies rashes, itching, or lesions. HEENT denies headaches, visual changes, sore throat, or nasal congestion. Cardiovascular denies chest pain, palpitation, or peripheral edema. Respiratory denies shortness of breath, cough, or wheezing. GI denies nausea, vomiting, abdominal pain, diarrhea, or constipation. GU does report mild brown vaginal discharge following colposcopy, resolved spontaneously, but denies dysuria, hematuria, frequency, urgency, abnormal vaginal bleeding, pelvic pain, foul odor, or cramping. MSK denies joint pain, muscle aches, or back pain. Neuro denies dizziness, weakness, numbness, or syncope. Endocrine denies heat or cold intolerance, polyuria, or polydipsia. Psychiatric denies anxiety, depression, or mood changes. Physical exam, so vitals. Her temp was 98.7 degrees Fahrenheit, heart rate was 70, respiration was 16, BP was 108/71, oxygen was 100%, weight was 69.9 kilograms, height was 1.59 meters, BMI is 28.02 kilograms per meter squared. In general, she's alert, oriented ×3, well appearing, female, and no acute distress. HEENT and neck, normal cephalic, atraumatic, conjunctiva clear, mucosa membranes are moist, neck supple, and tracheal midline. Cardiovascular, she has regular rate and rhythm, no murmurs, rubs, or gallops, or no peripheral edema. Respiratory, lung clear to auscultation bilaterally, no wheezes, rales, or rhonchi, no labored respirations. Abdomen, soft, non-tender, non-descended, no rebound or guarding bowel sounds present in all quadrants, no hepatomegaly. GU, external genitalia without lesions or discharge, vaginal mucosa pink and moist, no active bleeding or abnormal discharge. Cervix is visualized without visible lesions or discharge, no cervical motion tenderness, uterus non-tender, and nexa non-tender without palpable masses. Skin warm, dry, intact, no rashes or lesions. Extremities, no edema, cyanosis, or clubbing, full range of motion. Neurological, alert and oriented, cranial nerves 2 to 12 grossly intact. Psychiatric, appropriate mood and affect, cooperative during exam. Workup, so we did a CBC back in, they did a CBC back in April, which was within normal limits. STI testing, she was negative for both chlamydia and gonorrhea, HIV, syphilis, and Hep B and C. HPV testing was done, and they did find that HPV 16 was negative, HPV 18 was positive. So then they ordered a colposcopy, and the pathologic results from 926 showed scant benign endocervical epithelia admixed with rare, very tiny atypical squamous epithelia with high NC ratio cells, suspicious for HCSIL or CIN 2 to 3. HG. Cervical biopsy of the anterior lip showed HGSIL, CIN 2 to 3, flat but detached fragments without underlying stromal tissue. And then the cervical biopsy from the posterior lip showed HGSIL, CIN 2 to 3, which detached fragments without underlying stroma, probably with glandular involvement, detached necrotic tissue adjacent to dysplasia of uncertain significance, and underlying invasion cannot be ruled out. So clinical corrections recommended. So then for the assessment, Mrs. ACG is 36-year-old old G2P2002 female with high risk HPV type 18 infection and biopsy proven cervical intraepithelial neoplasia grade 2 to 3, which confirmed on colposcopy following an abnormal pap smear showing HSIL. She is currently asymptomatic with no ongoing vaginal bleeding, pain, or discharge. The patient is being evaluated in preparation for a cold knife conization procedure for diagnostic and therapeutic management of high-grade cervical dysplasia. There is no sign of infection or active gynecological pathology at this visit. Patient is medically stable and appropriate for elective surgical interventions pending completion of pre-operative labs and clearance. Plan. So we're going to order some labs, CBC, CMP, PT, INR, APTT, urine pregnancy test, and type and screen. We're also going to do infectious screening, so confirm negative status for HIV, syphilis, and Hep B and C. We'll also probably check for chlamydia and gonorrhea. EKG, evaluate for heart health and see if there are any underlying heart conditions. Transvaginal ultrasound to check for any abnormalities in the cervix, uterus, or surrounding organs. And then we also have to consent patient and discuss risks, such as bleeding, infection, cervical stenosis, infertility, preterm birth risk, and the benefits and alternatives, such as LEAP and surveillance. Patient verbalizes understanding and consents to proceed. And then we'll proceed with a cold knife conization to have an excisional biopsy to remove transformation zone and confirm margin status for CIN 2 to 3. Advise patient to be NPO after midnight the day before. So now I'll be talking about cervical dysplasia. Epidemiology. Cervical dysplasia is the presence of abnormal precancerous cells on the cervix, most often caused by persistent HPV infection. It is diagnosed through a routine pap smear test, which collects and examines cervical cells for abnormalities. Cervical dysplasia most frequently affect women between the ages of 25 and 35. Incidence is higher in sub-Saharan Africa, Latin America, Melanesia, and some parts of Asia, with lowest in high-income areas. There is a strong link between socioeconomic status and the incidence and mortality of cervical cancer. Rates are significantly higher in countries with low human developmental index compared to those with very high HDI. Trend currently has been declining in some high-income countries, while rates have been increasing in some parts of the Eastern Africa and Eastern Europe. Prevalence in the U.S. is between 250,000 and 1 million women are affected by cervical dysplasia each year. Cervical dysplasia is graded mild, moderate, or severe based on severity of the cell abnormalities. Now, etiology and risk factors. The main cause is persistent infection with certain types of HPV, especially high-risk strains such as HPV 16 and 18. While most HPV infections are cleared by the immune system, persistent infection can lead to developmental of precancerous changes to the cervix. Higher HPV viral loads and longer lasting infections are key risk factors to dysplasia recurrence. Another risk factor is sexual history, so early sexual activity at a young age before 18 increase the risk, and also multiple partners also increase exposure to HPV. Smoking increases the risk of immune system failing to clear the HPV infection. And then weakened immune system for either HIV or immunosuppressant drugs can lower the body's ability to fight the HPV infection and increase its progression to cancer. Now the pathophysiology. Typically, HPV infections such as 16 and 18 affect the squamous epithelial cells of the cervix, the typical site of this occurring seen in the transition zone. Viral replication and gene expression occurs in infected basal cells, which then differentiate and move to the surface. The HPV genome starts expressing its oncogenes, specifically E6 and E7. The E6 and E7 protein then interferes with the normal cell cycle by targeting and inhibiting tumor suppressor proteins such as P53 and RB. This interference removes the normal checks on cell growth, leading to uncontrolled and abnormal multiplications of the cells. The abnormal cells show immature features and increased mitotic figures, which become visible on colposcopy and can be graded. If left untreated, this process of uncontrolled cell growth can eventually lead to invasive cervical cancer. Clinical manifestations. The most common clinical manifestation is the absence of symptoms, which is why routine screening is important. So the majority of the patients are asymptomatic. They may be able to notice a change in vaginal discharge, such as unusual color or odor. Maybe abnormal bleeding can be a symptom. This can include spotting between periods, bleeding after intercourse, or heavier than usual menstrual bleeding. Another thing that can be seen is possible pain during or after intercourse or general pelvic pain, which can be a symptoms. But the majority of the clinical manifestation comes with no symptoms. So that's why screening is important. So workup, initial screening is a pap smear. Pap checks for abnormal cells on the cervix. Abnormal changes are described as low grade, high grade, or possible cancers. HPV test is also done sometimes. It can be done with co-testing, which looks for the presence of human papilloma virus, which can cause cervical dysplasia. Follow-up diagnostic tests include colposcopy if the initial PAP or HPV test is abnormal. Providers use a colposcope, a magnifying instrument, to examine the cervix for any abnormal areas. Biopsy during the colposcopy, the provider will take a small tissue sample of any abnormal areas to be examined and sent to the lab to determine the severity. And then there's also endocervical curettage, which this is considered a deeper scraping of the cervical canal, which may be performed to obtain more cells for testing. Now, advanced procedures, there is LEAP, which is a loop electrosurgical excision procedure. This is if the biopsy shows moderate to severe dysplasia. LEAP may be performed. It uses an electrical wire loop to remove the abnormal tissue. And then there's cone biopsy, also known as conization. This is a surgical procedure that removes a cone-shaped piece of tissue from the cervix and then it can be used to diagnose and or treat the moderate to severe dysplasia. Now this is the grading system. So these are different types that can be seen. So obviously papillomal classification 1 means that it's negative. That's a negative for intraepithelial lesion of malignancy. Papilloma classification 2 can either be squamous atypia or mild, and oscus, which is an atypical squamous cell of unknown significance, or low-grade squamous intraepithelial lesion, which is squamous atypia CAN1, also known. And then the abnormal cells in 1 to 3 of the layers, very unlikely to progress. Now, papilloma classification 3 is moderate, which is known as a high-grade squamous intraepithelial lesion, CIN2, which is abnormal cells including mitotic figures in a 2 out of 3 of layers with loss of stratification and differentiation. This can also sometimes include CIN3, which is abnormal cells in all layers that can progress to an invasive cancer if left untreated. And then papilloma classification 4, which is a severe CIS, carcinoma in situ, which is a high-grade squamous intraepithelial lesion. Again, these abnormal cells there's abnormal cells in all layers and can progress to an invasive cancer. And then 5, carcinoma. That's just malignancy everywhere. So that's the grading system. Now I'll be talking about the cold knife conization. So CKC is a surgical procedure that involves removing a cone-shaped piece of the tissue from the cervix using a scalpel. This is used for both diagnosis and treatment. The patient is placed in a lithotomy position. A speculum is inserted into the vagina to visualize the cervix. A solution may be applied to the cervix to highlight abnormal areas. Typically, they use vinegar solution, such as acetic acid, to make it more visible, but they can also use, in some cases, Lugol solution, a supersaturated potassium iodide solution, which is also used and can be very helpful. Then a scalpel is used to cut out a cone-shaped piece of off tissue from the cervix. That tissue is then sent to the lab for testing, and then stitches is then used to close the incision. Recovery: most patients can go home the same day as the procedure. Bleeding and vaginal discharge is common for several days. Pain can be managed with over-the-counter pain relievers, and sexual activity and strenuous exercise should be avoided. Risk: there's always a risk whenever going under a procedure, so bleeding, infection, damage to the cervix or vagina, and infertility, which is really rare. The benefits of these procedure is the effective treatment for cervical dysplasia and early stage cervical cancer, can provide definitive diagnosis and may reduce the risk of recurrence. Now, management for cervical dysplasia, as I said, there's different treatments. There's LEAP. Treatment is dependent on the severity of the dysplasia and the patient's overall health. So when we talk about mild dysplasia, so CIN1, often no treatment is needed, but regular follow-up with pap smears or HPV testing is recommended, typically within a year. Moderate dysplasia, treatments include cryotherapy, which is the freezing of abnormal cells, laser therapy, or LEAP, which is a loop electrosurgical excision procedure to remove the abnormal tissue. Here I put a picture, and you can see how the electrical surgical loop cuts part of the cervix cuts part of the cervix that are abnormal. And then this severe dysplasia CIN3, cold knife conization or hysterectomy is considered. Now I'll be talking about HPV vaccination and the importance of it. So HPV vaccination prevents the infection that causes cervical dysplasia, significantly lowering the risk of its development and recurrence. While vaccination is most effective before any sexual activity, it can still be beneficial for those who are sexually active. Studies have shown that adjunct HPV vaccination given after treatment of existing dysplasia can significantly reduce the risk of recurrence. The vaccine can be beneficial for women up to the ages of 45, though it may be less effective. Vaccine does not treat existing infection, meaning that if you already have HPV infection, it won't cure it. But there's other options to help with the HPV infection. So there's different vaccine schedules. So ages 9 to 14 who are not immunocompromised typically get 2 doses, one administered at that age range, and then the second one 6 to 12 months after. If you're ages 15 to 26, or ages 9 to 26 with weakened immune system, you get 3 doses. So again, you get the first dose, whatever age you are. Then you get the second dose 1 to 2 months after the first dose. And then you get the third dose 6 months after the first dose. And then ages 27 to 45, vaccines are not routinely recommended, but if they choose to be vaccinated, they will follow the 3-dose schedule. And then here I put how HPV vaccines were approved for ages 27 to 45. This was recently done, and there are more than 200 types of HPV viruses. More than 40 of them can easily spread through direct sexual contact. Every year, about 14 million Americans become infected with HPV, and it can take about 10 to 30 years from the time of an initial HPV infection until a tumor forms. And then HPV causes more than 33,700 cases of cancer every year in the US. So this is why the importance of HPV vaccination is so important. It helps prevent cancers, and it's can use both for women and men as well. So the next slide is my references, and that is my presentation. Thank you.